All right, I wanted to jump back on here and do some metabolic derangement. So I mentioned in that first video that this is the cell, and our number one intracellular ion is potassium. And I don't know if we can make that red. And the number one, excuse me, extracellular ion is sodium. Oh Lord, I don't want my lap. Now I don't know how to get rid of it. Let's see if there's an eraser. There we go. So number one extracellular. Give me a second. Just write these out here. Is sodium. Thank goodness I can finally get those in there. And then we, of course, calcium plays an important role with keeping this cell membrane together. And, oops, too many A's. And the movement of electricity, this force of contraction. So here's everything in our resting membrane potential. So let's talk about derangement or problems with these electrolytes. And one of the first ones you're going to hear of is going to be hyperkalemia in renal failure patients. And we hear about it so much in the South because, you know, we're kind of in the renal failure belt of the world. It's amazing the amount of renal failure we have in this state. And when I go back to Indiana frequently, it's hard to find a dialysis center, but I mean, they're in like seems like every small town here. Every town has a darn dialysis center. So, or several. So with hyperkalemia, I think you guys already know that means there's too much potassium outside of the cell. So I'm just going to put these out here. And I referred to it in that last video as free potassium. When they check someone's potassium level, they stick a needle and they draw blood. So this would be our needle here. And they're drawing blood, and that's where they get these potassium levels. So when they draw the blood, all that potassium is then collected in this thing, and then it goes to the lab. And depending on what book you read, 3.5 to 5 would be potassium levels. I've also seen 4 to 6 written in some books. So it depends on your reference material. But whenever you have too much potassium outside of the cell, it's called hyperkalemia. And as referenced earlier, that happens with dialysis patients a lot. So anytime you have potassium outside of the cell, especially hyperkalemia, it slows down muscle function. It slows down everything because it slows down ATP's ability to reset to get that potassium moving. It now doesn't want to go from, high concentration to low concentration and back and forth because there's a lot of potassium everywhere. So it makes the repolarization harder. And when you start thinking about the T waves, because T waves equal repolarization of the ventricles, you'll end up with these really tall, it's hard to draw with this thing. You end up with these really tall T waves, where normally it would just be a nice bump, maybe half the height of that QRS complex. I'm drawing with a mouse, which is extremely hard to do. Wow. So you have to forgive me for these crazy looking waveforms. So when you think of hyperkalemia, you can think of big T waves, and you can also think of like bradycardia, and eventually it widens out the QRS complex too. So you can end up with these big wide QRS complexes. And maybe down the road, you'll end up with something that looks like this. So you have this slow, and this term's called sinusoidal. It's just as positive as negative rhythm. And these people are usually in PEA or asystole when you find them. But it's kind of the hallmark of hyperkalemia with these renal failure patients is when you show up and they're in a cardiac arrest and you put them on the monitor and it kind of looks like this. There's not a lot going on. And, you know, what we're trying to do for PEA is PEA. So PEA equals PEA. It's problem, which means your H's and your T's, and you'll learn what these mean. Epi. And airway. So when I think of PEA, I think of PEA. So problem, epi, airway. Now, when you start looking at your the American Heart Association's the way they set up your algorithms, it will basically look a little bit different than what I just drew. So theirs will kind of look like this when you look at their algorithm. It'll have something like that. It'll have you consider whether or not you want to do an advanced airway based off the compliance of the BVM. And then it will have you, IV, IO, a milligram of epi every 3 to 5 minutes throughout the asystole / PEA arrest. And then it will have you consider your H's and your T's. And the problem with this that I've seen now, and I'm not saying that all paramedics do this, but what I've seen paramedics do is that it takes time to get from the advanced airway. It might take a couple minutes to get that advanced airway placed. And we know from studies, there's a study, I think it was called EPIC or something, but that showed that early epinephrine has better outcomes on patients. So you could delay that first dose of epi, which is not good for the patient. And therefore, you've seen a kind of de-emphasis in advanced airways because we don't want to delay giving epi. So, but let's say you decide you're going to intubate this patient. It might take 2 minutes. Stand by medical station 1, stand by medical station 1. I got a call. All right, I'm back. Had to go run a call. Can you believe that? It's out here abusing me. So I'm not sure where I left off, but it looks like I was talking about how a lot of times paramedics will delay the H's and the T's when they're working PEA, asystole, cardiac, really all cardiac arrest. The key is finding a reversible cause quickly. And if you're following this kind of AHA recommendation, it could delay you if you're, trying to figure out H's and T's. So what I do, because I'm special, is I switch it around and I put my H's and T's up front, which are the problems. And of course, we're going to give epi and any other drug related to the H's and the T's and airway. So, and that doesn't mean that I'm neglecting the airway. Of course, if I can't intubate the patient or ventilate the patient, then we have an issue that we have to immediately sort out. But if I'm able to OPA and bag that patient, then I put more emphasis on the early administration of epi. Whoop, didn't mean to do that. And then I'm working out. Anyway, I'm doing all these things simultaneously because, I'm not just a cookbook paramedic, but I don't know why we're even talking about that now. So yeah, for asystole and PEA, I use the term PEA. What's the problem? Epi and atropine. So let me go back to this. Okay. We were talking about hyperkalemia. Let me get back on track here. We have too much potassium outside of the cell, and it slows down muscle function. Here's our sodium. Put the sodium out here. No, I don't want you to be. I want you to be red, but okay, you are what you are. That potassium there is living its best life, and I'm cool with that. Here's our sodium hanging out. This is, again, that resting membrane potential. So I want you to think about those dialysis patients, and they're at high risk for hyperkalemia, which you'll hear that over and over and over again. What you generally don't hear is before, why, well, let's make it up. Why is this potassium outside of the cell? Well, let me direct you back to the calcium. Calcium's job is to bathe and keep the cell membrane together, and therefore sequesters most of the potassium. A little bit of it does leak out, but predominantly it holds the potassium in the cell. With our patients who are those renal failure patients, they can get in metabolic derangement where they get low on their calcium. That was supposed to be white. And what happens is when they become hypocalcemic, oh, look at that, it's still there. When they become hypocalcemic, come on, man, help me out with this thing. I really need to get a better drawing app so I can do this without this. It says draw. There we go. Look at that. When the patient becomes hypocalcemic, oh Lord, help me, Jesus. What do you think happens to the cell membrane? Well, the calcium's not there to keep it together. And remember, calcium plays an important role in the movement of electricity across the membrane. And so is the speed or velocity of depolarization. And it also plays an important role in the contraction of the muscle. So if you start losing calcium, then you could hopefully easily see that their heart rate is going to slow down. So they can get into Brady dysrhythmias, and the force of contraction slows down, which both of those affect cardiac output, which drops the patient's blood pressure. Now, these insanely, the insane metabolism of these dialysis patients, they're usually extremely hypertensive. And so it could kind of delay those symptoms that you would expect to see because of their crazy hypertension they normally have. So in this patient here, we're going to say they become hypocalcemic, which leads to this potassium leaving the cell. So this potassium is no longer kind of sequestered, it just leaks right on out. And when that happens to all these other cells, you end up with hyperkalemia. So how do we transfer that? How do we get the shift? How do we shift that potassium back into our cell? Great question, glad you asked. So we need to cause a fluid shift. There we go. We can cause a fluid shift and force the potassium back into the cell. And one of the medications that causes that is sodium bicarbonate. And sodium bicarb will return this potassium into the cell. Now, one of the things that's going on behind the scenes of this metabolic derangement is the hydrogen ion. When the patient becomes acidotic, they get this buildup of hydrogen ions. It becomes more positive outside of the cell than inside of the cell. And what happens, the hydrogen then enters the cell. There's a way to make those bigger. I don't see anything to do that. No. And to try to maintain that electrical gradient, it actually bumps the potassium out of the cell. So acidosis causes hyperkalemia, because the hydrogen ion is now occupying the cell. Whenever we push sodium bicarbonate, it binds to this hydrogen ion. It creates basically water and carbonic acid, right? So you're going to pee it off and blow it off. So the bicarb will then free up the cell for the potassium to go home. And then now we have the potassium back into the cell. You'll see some return of, faster rhythms. I like to give the example of this whenever you'll see this a lot. Someone will go out and work a cardiac arrest that's in PEA, and they'll push epi for a few rounds. And then someone's going to say, we should consider our H's and the T's. It's like 15 minutes into the code. And someone's going to say, well, let's give sodium bicarb because they've had an increased or prolonged downtime. And we would assume that they have, increased hydrogen ions, which is one of the H's and the T's. One of the H's of the H's and the T's. So they'll push the bicarb, and sure enough, they get pulses back. And think about this. They've given them maybe 3 rounds of epi. So it's 3 milligrams of epi on board. And it's just it's in a low flow state. So they haven't really metabolized that epi. And then now they've given the bicarb and they got pulses back, and their heart rate shoots up to 125. So they'll high five each other. They'll call the ER, local ER, this is medic, whoever. Be advised, we have return of spontaneous circulation. Patient has a sinus tach at 125. And they're going to be hypotensive. Why are they hypotensive? Well, if calcium plays an important role in the contractility of the heart, maybe we need some calcium in there, right? Because it's going to help with force of contraction. And maybe they're 125 because now they have to metabolize. They got to deal with all this epi that's, in their system. So they get on the radio and they give their celebratory radio report. We'll be there in 5 minutes. And what happens to that patient upon arrival at the ER? 9 times out of 10, as they're walking into the ER, they lose pulses, or just upon arrival. And then now you're walking in doing chest compressions again, and the ER is like, oh, I thought you guys got pulses back. Well, we did, but we lost them. And guess what? As crazy as this sounds, the entire kind of code starts all over again. The doctor's going to walk into the room and they're going to order epinephrine. And then they're going to give some more epi. And then they're going to give some more epi. So another 15 minutes later, they're like, let's consider our H's and the T's, because they're following the same AHA script that you might have been following in the field. And then they finally get around to considering, this hydrogen ion and whatever. But imagine this. Imagine if you realize that the patient has hypocalcemia. Oh, wait a minute. Time out. Let me back up. Why did that patient go back into cardiac arrest? Well, if you didn't secure the cell membrane, the potassium is just going to leak right back out. So in about 5 minutes or so, the potassium is going to leave the cell, and they're going to be back in that same metabolic derangement they were as when you found them. So imagine now, though, if you understood these basic concepts, and I think you'll get it. What if we would have gave, oh, look at that big old thick brush. We don't want that. What if we would have gave some calcium? So we give calcium gluconate or calcium chloride. Look at me trying to draw a circle. We give the calcium, and what does calcium do? It actually bathes the cell membrane and it holds it all together. And it also plays an important role in the movement of electricity, so it speeds up velocity, and it also helps with force of contraction. So if we give the calcium, then give the sodium bicarbonate, we will keep the cell membrane together, and then we will force the potassium back into the cell. We will cause that fluid shift. Potassium goes back into the cell like it's supposed to, and that patient should not go back into cardiac arrest. Once we get them converted and we move the electrolytes, then we'll have, a sinus rhythm at 90 or whatever. And if you can think about doing this early in your code instead of 15 minutes into the code, the patient's going to have a better outcome. The quicker you reverse them, the better. The quicker that, or the better the patient's neurological outcome is going to be. In the hospital, it's a little bit different. They're going to give that patient insulin because that's the key to the cell. It opens it up. They'll give them a little D50 also because insulin, of course, is going to drop that blood glucose level. And when the cell's opened up, the potassium will go back in. Well, guess what? We don't carry insulin. So I don't know. Hopefully all this made sense. I'll try to do while working, but that's just an example of some metabolic derangements. Hypocalcemia usually leads to the hyperkalemia. So you don't want to just fix the hyperkalemia without addressing the hypocalcemia. And the calcium, you just have to know the concept. It plays an important role with the movement of electricity and the force of contraction. So if you give your patient calcium, you would expect to increase heart rate and increase force of contraction. If you give a calcium channel blocker, you're going to slow the heart rate and slow down force of contraction. Both of those affect cardiac output. All right, I'm going to just stop it here because I have to write my report. I hope this was helpful. Anyway, if you need me, text or call 356-0002 or Merle@pdrems.com. Okay, I'll dream up another one in just a few minutes, but that's the end of this video.